Appreciate that. All right. So can folks see my screen?
So for some reason, the screen share went away. So try again.
Okay. How about now?
No, I think you just try stopping and resharing the whole screen again.
Okay. Can you see it?
Yeah, I can see it's like the regular PowerPoint view, not presenter.
Oh, we're at the.
Yep.
Okay.
That looks like it's working. You just have to go to the beginning.
Okay. All right. Thank you so much. I am talking today about the KDIGO 2021 guidelines and have titled my talk, Blood Pressure and CKD, Will the Real BP Please Stand Up? And the outline of my talk will be that I'm going to start by talking about the history and implications of the 2021 KDIGO guidelines and talk about the different types of blood pressure measurements, as well as the difference between standardized blood pressure measurements and other blood pressure measurements, and then talk about automated office-based blood pressure measurement and out-of-office blood pressure measurements and patient education. I decided to talk about this because I really enjoyed working with Dr. Avara in the Harborview Hypertension Clinic, and I wanted to learn more about the KDIGO 2021 guidelines and the data that is kind of upholding them, and understand how I might implement this better in my clinical practice. So I will start with a poll, or start with a case. So this is a patient that I've been seeing with Dr. Shannon and Dr. Cormack. He is a 45-year-old man with longstanding type 2 diabetes, hypertension, CKD stage 4, nephrotic range proteinuria, and a prior stroke. He is on irbesartan 150 milligrams daily, which has been limited by hyperkalemia, and also empagliflozin and liraglutide and aspirin. These are his last clinic blood pressures, and I'm seeing him on January 12th, and his blood pressure is 132/85. He does not check his blood pressures at home. So based on these blood pressures, I wanted to do a poll. What would your next steps be for his blood pressure management? A, no change. B, have him check home blood pressures, and if consistent with these, then add a second blood pressure medication. C, refer for ambulatory blood pressure monitoring, or D, add a second blood pressure medication. We're going to launch a poll, and sounds like there's two parts of the poll, but just answer for the first one. Oh, I see. It's not actually letting us share. It won't let you submit unless you've actually answered both.
People
So
can
just
pick a random answer.
Yeah, pick a random answer for the first. Okay, so this is great. So it looks like a lot of people would have him check blood pressures at home, and then if consistent with these, then add a second blood pressure medication. Some said that they would refer for ambulatory blood pressure, and just a couple said that they would add a second blood pressure medication with this information, and then some would not do anything. Okay, great. So that's great to hear what people would do. And this is kind of the crux of what I wanted to talk about as patients like this and how we might understand the KDIGO guidelines as they relate. So in order to better understand the KDIGO 2021 guidelines, I wanted to go over the history of blood pressure recommendations for CKD. In 2003, JNC recommended a blood pressure of less than 130/80 for patients with CKD. And then in 2012, KDIGO came up with a blood pressure recommendation of less than 140/90 for patients with CKD and less than 130/80 for patients with albuminuria based on the ASK and MDRD trials. In 2017, ACC and AHA recommended a blood pressure less than 130/80 based on the SPRINT study. And then in 2021, KDIGO recommended a new blood pressure guideline, a single blood pressure guideline for patients with CKD of a systolic blood pressure less than 120 when tolerated and when using standardized office blood pressure measurement. So this is, again, a single blood pressure recommendation for all patients with CKD. And it's also the lowest blood pressure recommendation that we've seen to date. And so this really impacts, number one, who we think has high blood pressure, and also number two, how we treat those who are already on antihypertensive medications. So to better understand the implications, this is the NHANES, a study that looked at NHANES data from 2015 to 2018 and identified 35.3 million adults in the United States with CKD. And based on the KDIGO cutoff, about 50% of these individuals would be eligible for a blood pressure lowering, and then about 6% more with the ACC/AHA guidelines, and then 70% of adults with CKD in the United States would be eligible for blood pressure lowering medications based on the 2021 KDIGO guidelines, which is 24.5 million adults in the United States and 7 million more than the previous KDIGO guidelines cutoff and 5 million additional adults compared to the cutoff in 2017 from ACC/AHA. So a huge number of individuals who now have high blood pressure. And in terms of treatment of these individuals, they identified 20.9 million adults who with CKD who are already on antihypertensive medications. And 75% of these individuals have a systolic blood pressure more than 120, compared to only 57% having a blood pressure cut of more than 130. So now 33.7 million additional adults who are on antihypertensive medications now have high blood pressure or are not at goal. And so an important point about understanding the KDIGO guidelines is that they stress and assume optimal blood pressure measurement, including standardized office blood pressure measurements, and then also suggesting use of out-of-office blood pressure measurements. And so when we talk about the types of blood pressure measurements, we're talking about in-office and at home. There's the standardized office-based blood pressure readings that are done in clinical studies with protocols and done the same way. And then there are routine kind of office-based, or sometimes the literature refers it to casual blood pressure measurements. And then I'll talk more about this automated oscillometric office-based blood pressure. At home, of course, individuals can check blood pressures at home on their own, and then there's ambulatory blood pressure monitoring. And so I want to talk more about standardized office-based blood pressures that are collected in clinical studies so we can understand the data that come from the SPRINT study. So this is a table that summarizes the protocols that were used and the type of blood pressures that were used for these landmark clinical trials, including Framingham, and most of them have a 5-minute wait period with multiple readings. In the older studies were using manual devices, and now the studies are using automated devices. In the SPRINT study, an automated oscillometric device was used. Participants were asked to wait in a quiet room for 5 minutes. They had 3 recordings at 1-minute intervals, and then in most cases, there wasn't an observer present. So that's just a sense of what's been done in the past for these studies that are shaping guidelines. And so then the question is, how do these standardized blood pressure measurements compare to office-based blood pressure measurements? This is a table that looks at office blood pressures and compares them to more standardized blood pressures that are done with a protocol. And usually the standardized or blood pressures are lower than the office blood pressures. And that's been seen across multiple studies. And then, what about SPRINT? So this was a study that looked at 3,074 SPRINT participants who had outpatient visits during the SPRINT study. And they compared their outpatient systolic blood pressures from the EHR and then looked at the trial blood pressures and then identified that a mean difference in the intensive arm was -7 points, and the standard treatment arm was about -5 points. And I think it's interesting that, based on the intensive treatment arm, the participants were at on average at goal in this study of, around systolic blood pressure of 120. However, during that same time when they were out in their clinic, they were not at goal, or, about 7.3 above goal. So then the question is, can we just add a single correction factor to our outpatient kind of routine blood pressures to extrapolate what our patient would have if they were a study participant? And the answer to that is no. So this is a Bland-Altman plot, which looks at agreement between 2 similar variables. The x-axis is the difference between the outpatient systolic blood pressure and the trial blood pressure. And then that was the y-axis, and the x-axis is just means blood pressure for both. And each participant is a single dot. The size of the dot represents an individual that had more blood pressure readings during that time. And only about 44% in the intensive treatment arm had a mean difference of 5 to 15 points for blood pressure during this time period. And they had a very wide agreement interval. And with the standardized treatment arm, only about 44% of the participants had a mean difference of 5 to 15. So it's not great agreement between, and you can't just apply a standardized correction factor. This was another study that looked at 275 CKD participants and checked blood pressure in a standardized way versus a routine way, and found on average a -12.7 difference between the standardized and routine. And they had a agreement interval of -46 to 20.7. So again, it's just poor correlation between standardized and routine blood pressure measurements. So that kind of leads me to, what is the real blood pressure? And as I was thinking more about this, I wanted to talk about improved blood pressure measurements in the clinic, how to utilize home blood pressure measurements, patient education, and then future research. In terms of improved blood pressure clinic measurements, this is a staff training, as well as it really can impact clinic flow. And I wanted to talk about automated oscillometric office-based blood pressure devices some more. So the automated oscillometric blood pressure is a device that will activate in a single, we'll do multiple blood pressure readings with a single activation. And it's a pre-programmed 5-minute rest time and then 3 readings in 1 minute intervals. And the good thing about this is that it's consistent with kind of the methods of the clinical trials, and it averages 3 readings, can reduce human error, and it can have less impact on clinic flow because the MA will, room the patient, set them up on the blood pressure, and can push the button and then leave. And because they can leave, it might mitigate the unobserved, their white coat hypertension or white coat effect, because it can be unobserved. And so then the question is, how does automated the AOBP compare to standardized blood pressures? Again, this is a table looking at a BP True device, which is an AOBP, and they found that actually it correlates pretty well, and in most cases was very similar to a standardized blood pressure reading, and in some cases even a bit lower. And in the Harborview Kidney Clinic, we had 2 AOBP devices. And now there are actually all 5 of our clinic rooms have AOBP devices. And starting in the spring, all patients who come to Harborview Kidney Clinic will have their blood pressure taken with an AOBP device. Now, how do we utilize clinic and home blood pressure measurements? So KDIGO, in addition to using standardized office blood pressure, suggested really utilizing home blood pressure measurements. And the reason why is because that can have a better sense of, what's happening, obviously, all the other days when they're not in clinic. And it can reveal a couple of phenotypes, one, of course, being white coat hypertension when the patient has high blood pressure in clinic but normal at home, and can also reveal masked hypertension where the participant has, or the patient has, normal blood pressures in the clinic, but then high blood pressures at home. And they found that these phenotypes of hypertension can be common in CKD patients. So for masked hypertension, just depending on the cohort that you're looking at, 6 to 50% can have masked hypertension. And then white coat hypertension has been seen in 3 to 41%. And I want to call out the work that Dr. Nisha Bansal is doing in this area. So she recently published a BOLD pilot study that did ambulatory blood pressure monitoring in ESRD patients, and now is just enrolling a study called Home BP, which is titrating blood pressure measurements in patients with ESRD based on their home blood pressures rather than their pre-dialysis blood pressures, and looking at things like intradialytic hypotension and other outcomes. So, and the thing is that when we look at cardiovascular events with these different blood pressure phenotypes, there is a difference between the different phenotypes. So this was a study of 466 patients in Italy with resistant hypertension who underwent ambulatory blood pressure monitoring. Those with kind of true resistant hypertension, or high at home and high in the clinic, had high CV events. And the masked hypertension group had a hazard ratio of 2.28, whereas compared to normotensive resistant hypertension participants. And white coat hypertension and those who were well managed at home and in the clinic were similar. So then the question is, why not use ambulatory blood pressure monitoring for everyone? To my knowledge, there are no large clinical trials that have used the average blood pressure or other metrics from ABPM as an exposure. And now, so therefore more studies are needed to know if ABPM actually improves outcomes for patients. That being said, ABPM is a powerful tool to assess white coat hypertension and masked hypertension, and you can see diurnal variation as well as response to treatment. And I've seen that Dr. Ibarra recommends it when we can't really figure out what's going on, but the patient will come in with very discordant blood pressures than what is being measured in clinic. This was, so a lot of these large blood pressure studies have had subgroups of participants that have undergone ABPM. And the SPRINT study actually had 897 participants that underwent ABPM at 15 clinical sites. So, and how does the daytime ambulatory blood pressure, systolic blood pressures compared to clinic? They found that they were on average a bit higher than the clinic measured blood pressures. That was seen throughout the different studies and different groups. Then I think another really important point is patient educations. These are examples of patient education. This was produced by the AHA. These are medical graphics that are in clinics at Mass General Hospital. I think just educating patients about how, having an empty bladder, not having run to your appointment and having your feet on the ground, how that can help them be empowered to make modifications when their blood pressures are being checked, not in the kidney clinic and maybe at their primary care visit and then just educating them about how to get an accurate blood pressure reading. So to continue our case, sounds like most people would think that he might need an initial blood pressure medicine. Then the question is, what clinical characteristics about this patient indicate he would more certainly benefit from a systolic blood pressure of less than 20? Is it A, his age less than 50, B, history of diabetes, C, prior CVA, D, severity of CKD and nephrotic range proteinuria, or E, none of the above? So we can launch the poll. And again, just pick whatever for the first one. All right. Okay, so it looks like a lot of people said prior CVA and severity of proteinuria and severity of CKD. A couple said none of the above. Some said history of diabetes, and a couple, it's kind of a smattering. All right, so the answer is E, none of the above. So when this is a table that looks at the certainty of evidence supporting systolic blood pressures less than 120, and the more certain is that folks that are older than age 50 and have a high risk of cardiovascular disease. The kind of less certain data is diabetes with CKD, stage 4 and 5, more than a gram of proteinuria. And, I have this slide that kind of goes over, the discussion points around the KDIGO guidelines, but for time, I'm going to skip it and just go to my key points, which is that the KDIGO 2021 blood pressure guidelines emphasize the need for standardized office blood pressure measurements, and the routine office blood pressure measurements are higher than standardized blood pressures, but really don't correlate well to the standardized blood pressure measurements. And AOBP is one way to improve office blood pressure measurements, and home blood pressures are critical for understanding blood pressures and identifying white coat hypertension and mast hypertension. And future research is needed to better understand these subgroups of CKD and also evaluate what aspects of the blood pressure measurement protocol that really impact the accuracy in the clinic. And I want to thank Dr. Avara for all of his help with the slides, and Dr. Bonsall, as well as the Harborview Hypertension Clinic staff.
Thank you so much, Laura, and have a few minutes for questions if people want to use the raise your hand or the chat, or just unmute yourself.
Or that looked like a good caveat slide. Do you want to discuss or mention some of the issues surrounding the KDIGO recommendation
Yeah, I can go back to that. So, basically concerns for AKI, concerns for polypharmacy and falls. And really the kind of take home is that, AKI was mild. They didn't see a difference in EGFR decline. And really the intensive group had less albuminuria. There was no effect modification from age or frailty. And they didn't see any difference in injurious falls or syncope or postural hypertension between the two groups. Yeah, go ahead.
Another question for you. How should we deal with that long list of caveats that you noted, where the evidence of benefit is lower?
Yeah, I think that, I think it's just helpful to understand, and that's what I love about this topic, is that there's a lot of gray areas, and just helpful to know, what data are supporting. And for me, and for this particular patient, I think really understanding the individual's cardiovascular risk is really important in making that decision. So that's how I interpret that. And, to not, even though that there's less evidence with those subgroups, it's still really important to understand that there were definitely differences between the intensive treatment arm and the standard treatment arm, and with little adverse events.
I had a question. Great job, Laura. I love this topic. I think it's incredibly important. There's been fairly low uptake of these new guidelines into practice. I think there's still a lot of concern that less than 120, even using, the standardized measurements may be too low. How can we convince people, and how can we implement this into practice? Do you have any thoughts?
Yeah, that's a great question. I think that's, I was thinking about that, maybe we need to try it and see how it goes, and have more experience with the guideline and seeing how patients do. I think also feeling confident about, that's why I think the patient education is really important, and making sure that the blood pressure readings that we have are as accurate as possible.
Maybe I'll just share my reflection on that as well. So one of the challenges, in my opinion, is that the SPRINT trial, of course, had the conventional treatment arm as less than 140. And so I think what I've seen is, this situation where a patient has a blood pressure of 132 in clinic, and what is the compelling evidence that really that patient's going to benefit from a blood pressure of less than 120 versus just trying to get to 128, less than 130. And, that trial will never be done. It would require too many people. So I think there's always going to be this uncertainty about, whether indeed it's worth it to go down to less than 120. And I think we'll probably all have to live with that uncertainty. Just one other reflection is just that one of the things that I've found is challenging about implementation of automated office blood pressure is, if it's not implemented throughout the whole healthcare system where the patient is getting their care, then you end up sometimes with a little bit of a back and forth battle with the primary care doctor or other providers about titrating the blood pressure medications. Their blood pressure may invariably be higher at their PCP's office where they're doing conventional office blood pressure. And there's not been an appetite thus far in the primary care setting in UW medicine to implement AOBP. They're sort of doing an alternative arrangement, which is they're repeating a blood pressure in the middle or at the end of the visit using a conventional office blood pressure technique, but it's not truly an AOBP. So I don't know that there's a way around that at the current moment, but just, a challenge. And, of course, another thing along with SGLT2 inhibitors that calls for interdisciplinary collaboration in the care of these patients.
And I just wanted to make one comment about out of office blood pressures. We actually did a qualitative study to interview patients on home BPs versus ABPMs. These were dialysis patients, and patients did both, and ABPMs are really difficult, so I think to do ABPMs at a regular enough frequency that's required to titrate medications may be challenging, and I would just push that home BPs may be a better option.
All right. Well, thank you so much, Dr. Mayeda. We'll